and where our case presenter is today. Gia is presenting from China. Gia, do you want to introduce yourself to the crowd?
Sure. Hi, friends. Nice to meet you online. And I'm Jia, a Chinese medical student, and currently located in China. And today, the case I'm going to present is a case I met around maybe 2 years ago during my rotation. And I prepared this case together with Dr. Minzhi Zhou, and we're very excited to share this case with you and hear more inspiring ideas from your discussion.
Awesome. Thank you so much for being here. Ravi and I are really excited to see your first case
Mhm.
presentation and to meet you and have you in this space. Ravi, do you want to say hi really quick before we get started?
Oh yeah, I hope everybody's doing well. Welcome to Tuesday VMR. I'm so happy to be here with my good friend Andrew, and I was just reminiscing with him the last time we discussed the case of myositis, and absolutely stoked to have a brand new presenter today, Gia, who's logging in all the way from China. So this truly is a global VMR family. So very excited to see what we have in store today. So back to you, Andrew.
Okay. If we could just get the screen shared, I think we can tackle the first aliquot, Gia.
Okay, let me start with okay. So today's case here, we had a 22-year-old male who presented to the ED with intermittent fever for 3 months and new onset severe abdominal pain. I think I would stop here. This is the chief compliment.
Oh, it's really interesting start already, Ravi. Okay, so I think what's most fascinating about this first aliquot is this is something that's been intermittent and severe for 3 months in a young person. I think it's just very telling because I feel like most young people like go to the ED, they're coming in with like a first onset, singular event like appendicitis, blah, blah, blah. But the intermittent nature of this already is going to make this kind of interesting. Ravi, I could go through like a fever differential really quick. I think what's going to be most helpful, though, is characterizing the abdominal pain more and getting some associated features. Probably a good review system since fever is part of the differential too. So really like fleshing out in the history a bit more what else could be going on with this patient that could be helpful clues. But I mean, fever, age-old differential on CP solvers is the IMAID mnemonic. So we have to consider infections in this patient, malignancies, autoimmune and autoinflammatory diseases, drugs and DVT, and endocrinopathy. And then Reza recently tweeted, it's helpful to kind of put specific things down within each bucket. So I'll just do some like type A, quick thinking responses to what this could be, maybe with fever and abdominal pain. Infections, intermittent fever, 3 months, and abdominal pain. The only thing I could come up with that's more chronic, like 3 months, these are things that would have to occur in like immunocompromised patients. So I guess we'll find out later on in the past medical history this patient has something like HIV or some sort of other immunodeficiency. But malignancies, I mean, intermittent fever, abdominal pain, I think of like bulky lymphadenopathy that's like necrosing, maybe like a lymphoma in the stomach could cause this constellation of symptoms. Other things that are like non-malignant, but related to lymphadenopathy would be like histiocytoses. We can come back to that if it's relevant later. Autoimmune, autoinflammatory diseases, a lot of diseases go under here. I'm actually working on a schema right now for autoinflammatory diseases, so I'll just make some mention that you can have things like FMF presents in adulthood, familial Mediterranean fever, where you have intermittent attacks of fever. That's like really a hallmark of the disease, and serositis. So you could have like, peritonitis with that. So that's a whole class of diseases, that being kind of the classic example that could fit for this patient. Drugs and DVT, we'll get a med rec, we'll hear about, kinetic causes, but nothing kind of like is fitting off the bat for that kind of category overlapping this presentation. And endocrinopathy is really like hyperthyroidism, which I don't think we have enough information to kind of call that. And then adrenal insufficiency is actually really, really fun cause of like fever of unknown origin. There's actually a great Emory Morning report where the FUO ended up being just adrenal insufficiency, and that can also cause abdominal pain. So definitely on the radar as well. But Ravi, do you want to tackle the abdominal pain part?
Oh my gosh, Andrew, you just did such a like a very good overview, very pragmatic approach to fever there. And I'm just wondering, maybe the answer lies within all of those features that you had mentioned, but you just used a very powerful tool, and I absolutely use that tool as well. And now to combine this with abdominal pain, kind of want to not dive deep into a diagnosis, but I usually will have an approach at this point. I think we need to see from more the history, more the exam, pivot points, which we can use to then maybe integrate this with the complaint of abdominal pain and fever to see if we can highlight something like you'd mentioned, inflammation, infection, endocrinopathies, autoimmune diseases, and so on. But I'm interested to see in the HPI, the time course of this abdominal pain. So if it was acute, so it's new onset. If it's acute, hyperacute, this could be a very nefarious process, maybe something like abdominal catastrophe. If it's more subacute, chronic, this could be something that could be sort of bubbling under the surface, maybe chronic pancreatitis and so on. Location is key as well, because we all love to use these anatomical approaches to abdominal pain. Also on exam, if there's any peritoneal signs. So peritoneal signs are very useful in case I think it has a good or very high likelihood ratio for something that could be very, it could be an emergency or abdominal catastrophe. Also in the vital signs, we want to look for, obviously there's fever, but if there's tachycardia, if there's hypotension, could there be volume depletion? Say there's associated volume loss through diarrhea, maybe hemorrhage and anemia, so that also will be key. And then also you want to look on the exam if there's any abdominal distension, which could also be, will clue you into maybe maybe there could be a maybe ascites brewing there as well. Could there be something within the abdominal viscous, maybe perforation, maybe there could also be obstruction. So a couple of approaches to abdominal pain. I'm interested again with the time onset, I guess severity also comes in there, location, if there's associated hemodynamic instability, which increases the urgency. Do we need to act on this? Or is this something that's sort of been brewing maybe in the subacute or chronic category that we have time to then sit back and think about it? Or do we have to rush and start implementing emergency procedures? So a couple of things to think about, but we'll get some of that information in the next aliquot. Back to you, Gia.
Okay, so here I will give more information about the abdominal pain and fever in the history of present units part. So actually, the patient developed the fever 3 months ago with a max temperature of 39 Celsius degree, along with the chills, fatigue, cough, myalgia, and pain in bilateral knee joints. His symptoms gradually improved with self-medicated Tylenol. However, 1 month ago, the patient started to experience postprandial mild abdominal pain and abdominal distension, along with nausea, intermittent low fever, and night sweats. This morning, he developed persistent abdominal pain with an NRA score of around 8 to 10, and vomited several times, which prompted him to visit the ER. The patient has had a poor appetite recently and has a weight loss of 2.5 kilograms. Okay, I will stop here.
There's quite a lot to digest. I'll take first stab at this, Andrew, and then see what you think. I'll swing the mic back to you after this. But I'm now, remember I kind of mentioned like what kind of points can you use from this? We've established a lot of different thoughts here, but what could we nitpick from the HPI to pivot on to maybe some diagnosis or some of the diagnosis we can highlight that you had mentioned. So that we already know about these sort of non-specific findings. There is fever, which we definitely highlight. Then there's chills, fatigue, cough, and so on in the myalgia. So this appears to be a systemic process, but then this abdominal pain is troubling me again. And again, I want to highlight this as a young person. So something happening in a young person, obviously I'm very worried they can compensate to the nth degree and then suddenly crash and burn. So we got to be really careful that we don't misjudge something that could be severe in this patient. But with this abdominal distension, I'm just kind of wondering, okay, what could you have in the abdomen? You could obviously have air. So air could occur from any sort of, say, a worst case scenario could be air from bowel ischemia, from perforation. But obviously, I'd look for other signs like guarding and so on, and also hemodynamic instability. Could there also be small bowel obstruction, large bowel obstruction? Could there be fluid from ascites? Could there be malignancy like you had highlighted before? Could there be blood, so hemorrhagic ascites from maybe pancreatitis, ruptured spleen, and maybe there's ascites from liver, although I'm not getting any signal for liver pathology in this patient, but the exam will be very helpful. So this abdominal distension is concerning, so I definitely I'm worried about that. And the fever could be secondary, rather than have some sort of esoteric infection causing this parasitic and so on. The fever could be secondary to what's brewing in the gut. So I think the gut is when we have to try and identify the problem, the abdomen is probably key in this. And you can see everything sort of coming secondary. There's anorexia, weight loss. So this has sort of been brewing for a while, and you see all these sequelae of this. But again, I'm not getting, although I was mentioning something that could be of an emergency situation that could put the patient in jeopardy, it could if it's not diagnosed. But for having this for 3 months is kind of unusual. So it's not going to be like a abdominal catastrophe like acute ruptured appendicitis or something along that nature. But while I'm kind of rambling, Andrew, what comes to mind with this? What could you add to the discussion?
Yeah, Robbie, I mean, there's, like you said, there's so much to work with here. I think it requires some rambling to really think about this hard and figure out how we can make progress, because you're right, we're dealing with something that's systemic, more systemic, and that could be so many different things. So 2 questions, Gia, for you, if you don't mind revealing. The fever, has it been more like continuous with high points, or is it more like they spike for a couple of days and like completely go away?
I feel like 3 months ago, when the patient first developed these symptoms, it's just like one very high temperature. But from 1 month ago, the patient has some intermittent fever, but not so high, just a low fever, low grade fever.
Okay, so like low grade fevers that are kind of like on and off, low grade. Okay, got it. Yeah, no, I'll take the fever approach again and just try and move some things lower on the IMAID differential with what's given to us. I'll start working my way backwards, like the E, like the endocrine. So for like the thyroid hypothesis, cough and bilateral knee joint pain, I don't think is like really fitting that at all. So I'm going to kind of take that off the table. And then adrenal insufficiency, just one other question, Gia. Any like orthostatic dizziness, like they stand up and they're having a hard time with dizziness or anything like that, or no?
No.
Okay.
No
That's a
orthostatic.
pretty sense. Okay. That makes adrenal insufficiency a little bit lower on the differential. Usually these people are like very like hypotensive and dizzy. So I think it's fair to say we're probably not dealing with something like endocrine. It's just kind of not fitting. Drugs, I mean, we're getting there, but I'm kind of not expecting it to be that. I'm not expecting this to be like DVT related. So I'm going to just take out the last 2 letters from IMAID. Autoimmune, autoinflammatory diseases. I mean, we have some joint pain here. So yeah, I think we're probably going to end up expanding on that differential. And I'm curious if the knee joint pain is truly like inflammatory. So, we're going to get that exam and see, is there a joint effusion there? Are the joints very warm? Does that joint pain get better like throughout the day, or does it get worse throughout the day? Things like this to kind of stratify, is that arthralgia an inflammatory or non-inflammatory, like arthritis kind of picture? Because it's bilateral and they're young, it's like very likely going to be inflammatory. So definitely thinking of the autoimmune, autoinflammatory diseases there. So A is like definitely on the table. Malignancies, cough would be like kind of weird. That wouldn't really like tie in too much, but we'll leave it on the table. And then infections, like certainly, like sure, like cough, non-specific symptoms, certainly. So I'll basically cut out the last 2 letters for my differential and leave the first 3 in, and kind of use I don't know. What should we do next, Ravi? It's always helpful, I think, when everything's like really not specific. I think about hard ways we can like make progress, like management wise. What should we do next?
I think, Andrew, you just, I was reading through recently a book and they talked about framing the differential diagnosis. You just clearly did that. You visualized your thoughts clearly there. You took your differential or your mental model and then you weeded out all the unlikely differentials according to the data that we got. So that's a very powerful maneuver that you just exhibited there. And I really like that thought process that we now honing in on the most likely causes. You know what's interesting? We've divided this into you taking the fever, I've taken the abdominal pain, and I'm just continue to focusing on this abdominal pain. And at this point, I think all of those are very valid points there, and I'm definitely going to keep them on the table and then refer to them as we get more data. But what do you think this postprandial abdominal pain and distension? I was sort of thinking, there's quite a bit of data building here, and it's very helpful to start building a problem representation. But I don't know if how much significance does this have? This patient is eating and then suddenly getting pain and then distension and vomiting. And to me, that would sort of signal there's some sort of obstructive pattern that's evolving there. So that could be something in the outlet of the stomach or maybe in the small bowel. So those are two key features I'm going to sort of track and see if that has any relevance and what could actually impact that area. So could it be something in the lumen? Could it be submucosal? Could it be externally compressing that area there? So something to think about in addition to all the wonderful thoughts that you had. Any other thoughts before we go to the next aliquot, Andrew?
Just one last thought, and I think it's a great question. I think there's so many symptoms, it's hard to tell how relevant that's going to be. But the strategy I've learned from the space and that I've used in real life that's been super helpful is just like asking the patient, like, what's the center of gravity for them? Like, is this postprandial thing just like a one-time thing that's not that bothersome? If it's the center of gravity, maybe we should think about it a little bit more. Gia, could you tell us, like, of all of these symptoms, if possible, it's okay if you can't tell us, what is bothering the patient the most here? Like, what is like worrying them the most?
I think when the patient came here, the most concerning problem for him is abdominal pain, because the abdominal pain started from 1 month ago, but actually at the initial time it is very mild. But this morning the patient, it become very severe. I will give more details in the physical examination, but the pain almost in the whole abdomen, but significantly in the left upper quadrant. And I think that this worsen abdominal pain is the main problems that prompt the patient came here.
Okay, that's very helpful. So yeah, Ravi, I think we can put some more cognitive effort into the abdomen, maybe even get some imaging later. So Gia, yeah, please move forward. I'm very curious what's next. This feels like a roller coaster of a case already.
Okay, let's start with aliquot 3. So for the past medical history, it's very weird that 6 months ago, the patient had a painless enlarged left cervical lymph node, and this lymph node got the surgical surgery, and the surgical pathology revealed chronic granulomatous inflammation with patchy necrosis. However, the anti-fast stain was negative, and the patient isn't in any medication currently. And for the family history part, the family history is unremarkable, and the patient is unmarried, has been smoking for 2 years, around half a pack per day, and he engages in social drinking. He currently is not employed now and denies any recent travel history. The patient is born and resides in China. He is allergic to penicillin. And so for the vital signs part, when the patient came here, he is afebrile, and the pulse is 110, respiratory is 18, blood pressure is 140 over 80 over 89, and the oxygen saturation is 98 percentage. And for the physical examination, the patient appears painful and in moderate acute distress, and the HENT examination is unremarkable. There is a clear breath sounds in his bilateral lung, and the cardiology examination is normal. For the abdomen part, his abdomen is distended, and there is tenderness throughout the abdomen, particularly in the left upper quadrant, and there is no rebound tenderness. The bowel sounds is hyperreactive, and the shifting downness test is negative. And for his extremities is dry, and there is no edema. So I will pause here.
Oh, Ravi, it's got exciting. We got a nice pivot here with the granuloma, I think, in the cervical chain. Unless that ends up being a misdirection, but I'm hoping it's related to what's going on. Ravi, do you have any gut thoughts on the granuloma? That's where I want to go next.
Yeah, you definitely made a great point there. This is a great pivot point. This really changes the whole narrative of this case now. Is it really, or is it going to lead us on a wild goose chase? Because this could be two separate, simultaneously occurring events, or maybe the clue is in there. So chronic granulomatous inflammation, AFB negative. So does that rule out TB? But then I'm going to go through my mental model for infectious or inflammatory causes of lymphadenopathy with fevers. So when you have fevers, I would also look for, are they accompanying night sweats? That could signal maybe in a young person lymphoma. We've recently had on VMR lymphoma cases. Could there be leukemia, and certain metastases do tend to gather in the lymph nodes? So this could be also secondary to solid tumor pathology. So then, like you had mentioned, Andrew had mentioned earlier, imaging will be key in this process. If there's a number of different lymph nodes within the abdomen and also within the chest, that could also increase our probability for maybe one of these diseases. Then we have to mention some of the wonderful diseases that several, Shema, Yasmin, and AMK, everybody's mentioning. TB, of course, is still at play. Also have to wonder about, actually, AMK she presented a great case on VMR once of CMV, so you have to think of the viral causes as well. So CMV, EBV in this case as well, HIV as well. This is a young patient, remember, so you can always have acute retroviral syndrome present like this. Then come the other sort of diseases as well, like Bartonella, Brucella. I don't know if the patient's been around cats, then Bartonella may be at play, rabbits, tularemia, and then toxoplasmosis could also be at play here as well. And then some of the autoimmune phenomena, patient is young again, epidemiologically, the patient could have manifestation of diseases, rheumatoid, unlikely, Sjogren's, lupus can manifest. I think we still have to entertain these, but at this point, I think I'm really into the metastatic category or bucket, and also maybe the viral and bacterial causes. But anything else you think about? I think Henry also put in the chat, syphilis is always also there, leprosy. And there are a couple of esoteric sort of diseases that a couple of people had put in there, which I think you can have histiocytosis, Castleman disease, sarcoidosis could also be at play, Kimura disease, and somebody had mentioned Kikuchi lymphadenitis can also be. I kind of have to look at that. My illness script is not robust for that, but that's something I think Yasmin had mentioned earlier. So, wow, I think rather than I think refining our hypothesis, we've probably generated more hypotheses at this juncture and makes us even more confused. But wonderful case, Gia, and you're presenting it truly so well. There's so much data here. But anything you would add, Andrew?
No, that was a really good list. I'm actually not even looking at the chat because there's already 99 plus comments and I can't keep up, but I did see all the ones you mentioned. I think one that's probably not going to be on the list too is, or not the final diagnosis, is Whipple's, because it's generally more chronic than this. That can also cause granulomas. And I'll just add some localizing value to the discussion and see how that helps us. So this guy does have cough. Could this be something in the lungs that we haven't yet visualized? So what if we see something like cavitary lung disease, like on a chest CT? That would be like super, super helpful. So the other thing is the abdominal pain in the left upper quadrant. So I'm translating that to splenomegaly. I'm hoping Gia's being nice and translating that easily for us. But yeah, there are a lot of chronic granulomatous diseases, that particularly infections, that can cause splenomegaly, which we already talked about that. Namely, it's like TB. We've had a lot of histo cases on VMR recently. So histo is definitely on the list. And there are other ones too, all these weird atypical infection we talked about. So I think what will be helpful is the basic labs, but also like chest and abdominal imaging to see, is there something hopeful in the chest that can help us pivot a little bit further. But yeah, let's go from there.
Yeah. So the next part is about some labs and imagings. Because the patient appeared with like so severe abdominal pain, so he received a lot of imaging work, and the abdominal X-ray revealed incomplete obstruction, and there is no intraperitoneal gas. And then the general surgery was consulted and just recommended conservative therapy. So for the labs, the CBC reviewed white blood count 5.4 with neutrophils percentage around 87, and the hemoglobin is 88 with MCV 85, and the platelet is 423. For the iron panel, the iron is 25, and the ferritin is 602, and the TIBC is 125, and the transferrin saturation is 17.2. And for the CMP part, the sodium is 134, potassium is 3.9, and chloride is 111, and the carbon dioxide is 19, BUN is 8, and the creatinine is 1, albumin is 2.6, and the transaminase and the bilirubin lipase were all normal. The LDH is 303.6, and the NT-proBNP is 7,200 around, and the hepatoglobin is normal. The ESR is 39, and the CRP is 24. For the urine analysis, it reviewed protein around 1 gram per liter, and also reviewed red blood cells in the urine. And the ASPAP serum immunofixation free nitrogen tests were all negative. The T-spot TB, a kind of blood TB test, is negative. And the EKG just reviewed tachycardia with heart rate of 110, and there's no acute ischemia change. Okay, I will pause here.
Ooh, okay. I'll synthesize some of this for us. So the patient has a normocytic anemia and thrombocytosis and a high ferritin, and then some mildly to moderately elevated inflammatory markers. I think all of that can be synthesized as evidence of like kind of chronic inflammation, like probably an anemia of chronic inflammation, a chronic secondary thrombocytosis, and the ferritin being reactive, the albumin being a little bit low, also being negative acute phase reactant. So, not surprising because the patient is presenting with an inflammatory syndrome, but we just have some objective evidence that's going on now. The UA is interesting. I don't know about the units for that protein, but I'm assuming that's an elevated protein, and with the red cells, we could translate that into being like on a nephritic syndrome. So we do that, Ravi. now we're suddenly dealing with granulomatous disease that can cause a nephritic syndrome. And this is all, a subacute inflammatory presentation. I'm going to reflect on that a little bit while I pass the mic to you.
Sure. Absolutely great breakdown of the labs there. You definitely, while you were walking us through the labs, I was definitely thinking along those lines, and you did a great job in highlighting the UA there. So nicely, everything's now put in red. That's significant. So this is interesting. Yeah, you just ended with granulomatous disease and glomerulonephritis. So you have to start wondering what kind of conditions possibly could manifest or result in GN. So with GN, you could have a whole host of maybe immune complex disease. You could have Potsi immune disease. You could have things along the lines of maybe Goodpasture syndrome. So you have to start wondering if any of those conditions could manifest with this patient. So the SPEP was negative, so myeloma unlikely at this point. And the LDH, I'm wondering if this is significant or not. Is this elevated? I don't remember the units. Do you know, Gia, if that's elevated?
It's just on the borderline.
So
Ultra
borderline.
borderline. Yeah.
Okay. So if borderline, I don't think it would have any significance, but renal disease, you would get LDH elevation. So LDH could come from a number of things, from hemolysis, from solid organ issues like maybe a pneumonia in the lung. Maybe you'll see it elevated with PJP infection. Maybe you'll see it with liver injury, cardiac injury. But then you can also see it with vascular disease, lymphomas, leukemias as well. But it's not high enough to have any significance. So at this point, ferritin is a little high. And about 2 weeks ago, we did have a great case of, I think it was histoplasmosis with hyperferritinemia. I wouldn't even put this within the hyperferritinemia range, but this is kind of interesting. But if you glance at the SED rate and CRP, they don't support a thought of an inflammatory condition, amongst one of which is infection. So there can be conditions where the SED rate CRP cannot be or may not be reflective of an infection or inflammatory condition. So, but we have to be careful we don't get sidelined by that. So it is very much at play that you could still have an infection or inflammatory condition. But again, looking at this granulomatous disease, I think definitely I would want, I know Gia probably has some more information of this biopsy to see what exactly was in that area. And we have to start thinking about if there was necrotizing or non-necrotizing. So non-necrotizing would be like histo, necrotizing would be TB. So we would have to at least see if there's any more information, and also maybe imaging that could be helpful. But I don't get a lot of signal from this. The GN is interesting. And again, is this a systemic process with a signal within the kidney? I'm not quite sure. But I'll kind of ponder over that with the next aliquot. Any other thoughts, Andrew, while I was kind of pontificating on my soapbox?
No, I'm clutching on to the hematuria as signal because I really have nothing else to kind of clutch on to other than like the cough and maybe something in the lungs. So, I mean, with that information, I'm going to go down that path and say, yeah, we need things like the ANCA levels, anti-MPO, PR3, the anti-GBM. Some of the stuff in the hypocomplementemia bucket, I don't think are so like granulomatous, like lupus, I don't think. And some of the infections too, I mean, infective endocarditis can cause like a glomerulonephritis, but I don't usually think of like granulomas with that per se, unless if I guess the endocarditis is like a granulomatous endocarditis. But in any case, I think starting off with those and then examining the lungs will be helpful. The other one I did see pop up in the chat, I think I saw AMK bring it up, is, what is it, IgA, like vasculitis, like, Schleimline purpura. I know that's associated with like abdominal pain and joint pain as well. So I don't know, maybe we're gonna end up going for like renal biopsy at some point since we kind of already have that like cervical lymph node biopsy under our belts, but probably the serologies is a good place to start. Some chest imaging again to see what's going on there. And yeah, depending on the chest findings, I think if it's a good chest CT, we could consider more like infectious workup too.
Okay, so I will go ahead with the imaging part, and I have to add some details because this patient actually received a lot of investigation at outside hospital and then come to our ER and admitted in our ward, and so I just try to combine all the informations in this case to present it as what we meet at the first time, and actually the patient. Like 1 month ago, when he had some these symptoms, he did some blood tests at outside hospital, and which revealed leukocytopenia with the white blood count around 3. And at the outside hospital, he indeed got a lot of passenger testing, which all come back as kind of negative. And so come back to the imaging part, which did at our hospital. So the lymph node ultrasound revealed reactive hyperplastic lymph nodes in groin, axillary, and neck. And the abdominal ultrasound revealed hepatosplenomegaly, and the mesenteric portal and hepatosplenovessel ultrasound were all unremarkable. The cardio echo revealed mild pulmonary hypertension and decreased left ventricular diastolic function, and there is also moderate pericardial effusion. The CT scan revealed pericardial effusion, bilateral pleural thickening, and also small amount of pleural effusion. And the CT abdomen revealed diffuse edema and the thickening of the small intestine, descending colon, and the sigmoid, and particularly in the left upper contra small bowel. Okay, I would pause that here.
Oh, Ravi, what's going on? there's so many findings.
This is yeah, rather data heavy, but you want to take a stab at it? Or?
Yeah. So you know, I think again we gotta summarize what's going on here. So there's profound like serositis, like it's pericardial effusions. I think I saw pleural effusions, or maybe I'm making that up, but there's at least pericardial effusion. Kind of hard to get that. So you know that and yeah, I don't know. Suddenly, you know, I was focused on that UA finding at first, right? But with everything else going on, now I'm kind of moving away from that typical like glomerulonephritis differential and kind of going back to the lymphadenopathy like perspective of what could be going on here, especially with like the hepatosplenomegaly that's highlighted, like the thickening of like all of the gut, like something else is going on here. I think we should kind of step away from the nephritic side of things and like take a bigger picture. I mean, shotgun things that come to mind are infections again, like TB. Did we just miss it the first time? Perhaps we need to resample a lymph node, and we need to do special testing, I think, for all of the weird atypical infections, like any PCR that's possible for the atypical infections. I think we should like go for. And yeah, the autoimmune diseases, I mean, lupus, I kind of think of with serositis and all these weird findings. And going back to infections, like syphilis can do like all sorts of weird things too. So I would send like RPR on this patient, get the HIV test as well and see if that ended up being positive. I'll pass it to you, Ravi, while I keep thinking, because we have some work to do.
Oh yeah, Andrew, I'm so glad I'm discussing with you today. So it's a joy to share the burden, and it's interesting. Like with each aliquot, we were thinking the diagnostic goalpost will be moving closer and closer, and we will be at least at this juncture at 1:45 be verifying our diagnosis or hypothesis. But at this point, the diagnostic goalposts are moving further and further away. And I was like, which one of the thoughts that we had earlier on are more likely and should be front and center at this point? But again, I think the key is to now sort of focus in, recalibrate our thinking, and then focus in on what data point was really striking initially. And I thought, I was thinking along the same points. Yeah, there's a lot of systemic signal with this, which could be, rather than call it signal, there's noise. So there's a multi-system inflammatory condition that's involving the serosal surfaces, the joints, the muscles, there's fevers. And then you have to start thinking what kind of conditions, especially with the early signal that you latched in on, which was the kidney. So definitely lupus keeps coming to mind. And then you have to wonder about other autoimmune phenomena that could include conditions like this. I know lupus in a young person definitely is something I have to think about. And I think you mentioned complement, having more data, especially in working up the kidney complement levels, will be helpful, because if the complement's normal, like AMK, sort of IgA nephropathy could be maybe more valid. But if there's complement deficiency, then we have to start thinking about autoimmune phenomena in this case. Cancer, again, lymphoma, definitely in a young person. And then the infections, I'm not quite sure. What could give you a fever for months and months? Maybe a subacute endocarditis, but then it wouldn't manifest in this sort of broad presentation. So I still do need a bit more of the data testing. At least I didn't see HIV, we'd mentioned before. Definitely getting an ANA will be helpful at this juncture. And then we're not seeing the signal in the lungs that you had mentioned. So the hepatosplenomegaly, you were smack on with causing the left upper quadrant pain. And then there's definitely a lot of lymph nodes that are involved. So there's definitely something that is infiltrating into these organs, and you have to wonder about, again, gram-negative infections and then autoimmune infections. But back to you, Andrew. Any other thoughts before we move on to the next
yeah, we got to keep going back and forth until we got some tests. While you were talking, I pulled up my infiltrative diseases schema, because let's use the hepatosplenomegaly. I think that's really helpful in telling. I mean, there's a lot of signal for infiltrative stuff, but just using that. The one thing I think we're missing is sarcoidosis. That could cause, chronic granulomatous inflammation, lymphadenopathy, and just like weirdness kind of everywhere. So I'll throw that on. The ACE test isn't a very good test for that, but it's something that we can use. I think, again, resampling lymph node with the infectious stains will be the most helpful thing. I think we should get like histoantigen. I think we should get ANA. I'm going through the rest of my list here. IgG4 related disease. I don't know. I'm not really getting that flavor of things. Amyloidosis. I'm not really getting that flavor too. Yeah, this is a really, really hard case, Ravi. I feel like the answer is going to be somewhere in the serologies or in some sort of like infectious stain of the lymph node tissues, or it's going to be one of these weird organisms. Yeah, what other things should we send to close out? Because I feel like we're getting to the end here.
I just love that. That was very powerful, just bringing up your schema just to supplement your thinking there. And I think front and center you had highlighted sarcoidosis there. And again, you had earlier on mentioned about looking at the lungs, and I think 2/3 of patients with sarcoidosis tend to have bilateral hilar lymphadenopathy. So does that immediately rule it out? How about the third of patients that won't have it? So definitely is still in play. And along with all the other thoughts that you had there, I think are very reasonable. So I would get some more data to see, at least we can narrow down some of these thoughts and then focus in on maybe lupus being a cause, histo, sarcoid. And again, TB is still at play here. So back to you, Gia.
Okay, so I think next coming to a very key, very important lab test that for the autoimmune part, the patient does have the decreased complement. The C3 is 0.276 and the C4 is 0.036. The ANA tutor is positive 1 to 1,280, and the anti-double strand DNA antibody is more than 3,000, and the anti-Smith antibody is also positive. The ANCA lupus anticoagulants and the anti-phospholipid antibody were negative. So the patient was finally diagnosed with lupus, and we also considered for the TB retesting, because considering for the next possible steroids treatment, and so we got the surgical pathology, the surgical sample the patient did 6 months ago, and retest it for any possible pathogen, and including the TB, but all come back as negative.
Wow. Gia, this case was crazy. Thank you so much for coming. I feel like dissecting these cases in the the hot seat, or I don't think we call it the hot seat here. I think we call it the cold seat, if I remember from the pandemic days, right?
Lukewarm seat.
It's the lukewarm seat. Yeah. It's way harder, especially when all these data points are flying at you at the same time. My first thought is, oh wow, that urine was actually helpful. All the additional data we got was just like manifestation of a system disease, lupus, and really that pivot we had with the UA ended up being helpful. What are your thoughts? Also, I want to know about granulomas in lupus. Actually, I wasn't aware of that, so I would love to learn from everybody in the chat.
Yeah, Andrew, I'm so happy that you were my co-pilot today and discussing such a difficult case. And it definitely challenged both of us, but it definitely makes us stronger. And after this, there'll be quite a bit of reflection. And I guess the topic of the day will be lupus, but I really appreciate it. I mean, Gia, you presented for your first case, such a data-heavy case. My gosh. That is just so much that you delivered in such an expert fashion. I think I'll be falling over myself trying to, like, where should I put all the information? It's just mind-boggling what you just presented. So, but I really appreciate you working hard to bring this case to us and presenting today. And it does take some time. And I really appreciate Dr. Mingyu for helping you with this case. And please do come back again and present such a great case. I just love this case, especially the diagnostic journey. We thought about so many different conditions, and definitely the landscape of infection to inflammation to autoimmunity and so on. And Andrew, you were smack on with the glomerulonephritis, and also then that prompted you then to get the diagnostic testing or the laboratory studies like the complement and ANA and so on. And that definitely helped, although there was a lot of smoke there, but you were able to look through the smoke and get the next appropriate test, which will get you to the answer efficiently. So I really commend you on that. And really happy that you were able to come on and discuss this case with me. So should we go on to the teaching points? And we have teaching points with Aisha.
Hello, Gia, thank you so much for the case. That was a really interesting case, an amazing discussion. Okay, so for teaching points, today we have a 22-year-old male that came to the ED with intermittent fevers for the past 3 months and new onset severe abdominal pain. So when we talk about fever, we have the mnemonic IMAID, which is infections. So infections could be localizing infections, distal infections, bacterial. Malignancy, we can think about lymphoma. Lymphoma is a pretty big one in this case. Leukemia. And autoimmune and autoinflammatory were really big ones. So one of the examples is familial Mediterranean fevers, which means that you get intermittent fever attacks with peritonitis. And then drugs, you can get NMS, neuroleptic malignant syndrome, and endocrine hyperthyroidism. So for our patient, we didn't really consider the last two, the drugs and the endocrine. They didn't seem very likely. So we focused on infections, malignancy, and autoimmune. And then when we talked about the abdominal pain, we have to think about, first we have to consider, is this an emergent case? Even though this patient had symptoms for 3 months, so we can't really consider any emergency cases or catastrophic causes. But they could have been if there was any peritoneal signs that could have been suggestive of it. So when we think about the abdominal pain, we have to see, is there distension? Is there any obstruction? Is there any perforation that could be due to ascites, any hemorrhage, any? So when we think about obstruction, we have to think about extraluminal, intraluminal, or mural causes. That could be due to hernia, tumors, gallstone ileus, or anything of that sort. And then the duration of the abdominal pain can usually determine how much attention we need to give to the patient. So in this patient, as I said, the abdominal pain and the fever was for 3 months, so it's most likely not going to be an emergent cause. And then we ruled out the drugs and the endocrine, and then we started focusing on autoimmune. And because this patient is younger and has joint pain, we are thinking about inflammatory causes. We're thinking about lupus. And then when on physical exam, in the history, when there was postprandial pain, this could potentially signal that there's obstruction involved, which could be either gastric outlet or small bowel obstruction, or, as I said, extraluminal, mural, or intraluminal. And when we look at cough in this patient, that could indicate that there could be a cavitary lung disease, and we would need to do chest imaging. It could be due to TB, it could be histo. And on the labs, we had positive inflammatory markers and high ferritin that could indicate that there is some kind of chronic inflammatory condition going on that we need to look into further. And then when we had the, and then we were considering glomerulonephritis. And for that, we need to get complement levels, C3 levels, C4 levels, we need to get NA. And for that, we were thinking about post-immune, good pastures, immune complex diseases. And then on labs, we also had SPEP negative, so that excludes out myeloma. We had LDH, that could indicate that there is hemolysis, any solid lung diseases, or vasculitis. And then we had a lot of, we were thinking about granulomatous diseases. And for that, we need to figure out if it's necrotizing or non-necrotizing. If it's necrotizing, we have to consider TB. If it's non-necrotizing, think about histo. And in this patient, we had a lot of lymphadenopathy. We had, so for that, we need to go back. Now we need to consider infections. We could possibly resample the lymph nodes. We need to go back and check for any syphilis, HIV, do histoantigen, check for if the patient might potentially have sarcoidosis. And this patient had a lot of multi-system involvement, and because of their age, we need to think about autoimmune. And this and the lupus diagnosis explains the multi-system involvement and the autoimmune. And yeah, thank you so much for the case.
That was incredible. That was a really hard case to summarize. Thanks for doing that for us and being here today. And one last thing that Ravi and I forgot, Gia, do you have anything you wanted to say before we close out the day?
Yeah, I just want to say why we want to choose this case, because it's kind of the patient have a lot of symptoms and very untypical clinical pictures. And actually, because in my home hospital, the rheumatology department is very strong, and so we got a lot of lupus case. And I feel lupus has a very diverse clinical presentation, and even some of this presentation even out of my expectation. And every time I met the lupus case, I was kind of sad, because all these patients are almost very young, nearly at my age, and some patients have to face a lot of issues like fertility issues for female patients. And I even saw a patient who diagnosed at around 18, and at that time she was just got accepted to the college and finished the high school. But due to the lupus, she suffered a very severe cognition impairment, and finally become kind of dementia. And so I feel lupus is kind of a disease that I really don't like so much. Yeah.
Thank you for spreading awareness about that, Gia. I think you're right. I think it's important we can recognize this so we can help these folks as soon as possible. But
Yeah.
Ravi, it was a pleasure being here with you today. I hope everyone's doing well and have a great week.
Thank you for your discussion. Yeah.
Bye.
Bye.